Anatomy of extraocular muscles. We have 4 rectus muscles, 2 obliques, and levator palpebrae superioris muscle. So we have 7 extraocular muscles. For the rectus muscles, they all originate from the apex of the orbit. We call it annulus of Zinn, which is fibrous ring surrounding the optic nerve. Each rectus muscle originate from their corresponding side from the annulus, like the medial rectus originate from the medial side of the annulus, inferior rectus from the inferior side of the annulus, lateral and superior also from the lateral side and from the superior side of the annulus. They all insert anterior to the equator by different distances from the limbus, posterior to the limbus. Medial rectus insert 5.5 mm posterior to the limbus. Inferior rectus insert 6.5 mm posterior to the limbus. Lateral rectus and superior rectus insert by 6.9 mm posterior to the limbus and 7.7 mm posterior to the limbus. These insertions are into the sclera. We cannot see it because it's covered by tenon capsule and conjunctiva. We have 3 axes around which the movement of eyeball occur. These axes are axes of Fick. As we said, there are 3, X, Y, and Z. Z-axis is the vertical one. X and Y are both horizontal axes. How we differentiate both? X-axis is a horizontal axis that passes parallel to the iris plane, so it's a transverse axis, while Y-axis is also a horizontal axis but passes perpendicular to the iris plane, so it's an antero-posterior axis. Movement around each one of these axes give different direction. What I mean with this, movement around the Z-axis, which is the vertical one, create adduction and abduction. Movements around Y-axis, which is the antero-posterior one, gives us the intorsion and extorsion. Intorsion is the inward turning of eye, or limbus moves inward, to simplify it, while extorsion is the opposite. It's the outward turning of eyeball, or the limbus moves outward. Movements around X-axis, which is the transverse axis, are elevation and depression. This image will show you the 3 axes of Fick. Antero-posterior axis, which is Y-axis, transverse axis, which is X-axis, and vertical axis, Z-axis. You can see movement. You can imagine now the movement around each of these axes will create which type or which direction. The intorsion, extorsion related to Y-axis, elevation, depression related to X-axis, and abduction, adduction related to the vertical axis. For the extraocular muscles, the rectus muscles, they are all supplied by third cranial nerve except the lateral rectus, which is supplied by abducent nerve. I mean the rectus only here. Superior, medial, and inferior are supplied by the third cranial nerve. The lateral supplied by sixth cranial nerve. Their action, medial and lateral rectus, only give adduction and abduction. For the medial rectus, adduction; for the lateral rectus, abduction. Superior and inferior rectus, they give 2 types of movement: the primary action and the secondary action. The primary action of superior rectus is elevation, and the primary action of inferior rectus is depression, which is best noticed when the eye is abducted. So if we want to test the elevation and depression of the rectus muscle, we have to abduct the eye. How about the secondary action of each one of them? For superior rectus, it's intorsion. For inferior rectus, it's extorsion. These are secondary actions. The primary actions only elevation and depression. If we want to test the secondary action of these muscles, we have to adduct the eye. If we want to test for elevation and depression, we have to abduct the eye. This is important. Now we are discussing the oblique muscles. We have two obliques, inferior and superior obliques. The inferior oblique is supplied by the oculomotor nerve, the third cranial nerve. Superior oblique is supplied by the fourth cranial nerve, which is the trochlear nerve. How about their origin and insertion? To simplify it, inferior oblique originate from the floor of the orbit just lateral to the lacrimal sac and inserts into behind the equator. So it inserts posterior to the equator. We said that the rectus muscle inserts anterior to the equator, while the oblique muscles insert posterior to the equator. The site of insertion is the same as the macula for inferior oblique, which is the posterior lower temporal quadrant. So any trauma access manipulation to this muscle might end with macular injury. How about superior oblique? To originate just superior to the annulus of Zen, so from the apex, and directed to the trochlea. Trochlea is a cartilaginous, fibrous cartilaginous structure situated at the angle between the roof and the medial wall of the orbit. It's designed for the superior oblique muscle. What I mean with this, the superior oblique, when it comes from the origin, it will be reflected by passing through this trochlea and then go to its insertion, which is the posterior upper temporal quadrant. So the inferior oblique insert in the lower posterior temporal quadrant and the superior oblique into the upper posterior temporal quadrant, both of them inserted posterior to the equator. Now we come for the action of the oblique muscles. The inferior oblique and superior oblique, just like the superior rectus and inferior rectus, they have primary action and secondary action, but it's different from the rectus. And that the primary action for inferior oblique is extorsion and for superior oblique is intorsion, while the secondary action for inferior oblique now it's elevation and not depression, and the secondary action for superior oblique is depression. They can do both actions, the primary action and secondary action, if the eye is looking in a primary position. I mean, both eyes are looking forward. If I want to separate these actions, I want to test the inferior oblique or the superior oblique for only the elevation action, we should change the position of the eyeball into adduction. So they will work as elevator and depressor in adduction, and they will work as intortor and extortor in abduction. This is important, and it's the exact opposite of the rectus muscle. Of course, when we want to test, we will test for elevation and depression and not intorsion and extorsion. So the best position to test inferior oblique and superior oblique will be in adduction, while the rectus muscle will be in abduction. Sequent is misalignment of the visual axis. We can call it sequent or strabismus. It carry the same meaning. We have two types of axes related to vision: visual axis and optical axis. Visual axis is line connecting the point of fixation, the point that we look at, and the fovea, which is the center of macula. While optical axis is anatomical line, not related to the fovea, not related to the point of fixation. It's just a fixed line that passes through the center of the pupil, perpendicular to the iris, and falls on the retina at the exact point in the center between the macula and the optic nerve. So it's an anatomical axis. The optical axis is just anatomical axis. The visual axis related to the point of fixation, and the fovea which is responsible for the best vision. The angle between two are the angle of Kappa or alpha angle. Whenever there is large angle Kappa, this means there is sequent. That means there is misalignment of visual axis. These are the terminology we use while classifying sequent, and not the classification. Manifest sequent, we call it tropia. Latent sequent, we call it phoria. Decompensated phoria, corrective movement. I will explain each of these. For manifest sequent, which is a tropia, is a type of sequent that present when both eyes are open and fixating. While latent sequent, phoria, when one eye is covered. So we disrupt fusion. When both eyes are open, there is a fusion. When we disrupt fusion, we cover one eye, latent sequent will manifest. Decompensated phoria is a type of phoria that become tropia. It's latent sequent that become manifest sequent. This happens when this person have weak fusion. He cannot keep his or her eye straight for a long time. He will develop tropia at some times. Corrective movement occur during cover and cover test, which is the test we do to determine the type of sequent, the degree of sequent, and so on. What I mean with corrective movement, while I'm testing for phoria, both eyes are fixating and open. We will close one eye. Behind the cover, one eye will deviate. This closed eye will deviate. This is phoria. When I remove the cover, the eye will return to primary position. This is the corrective movement. Another terminology, which is iso, exo, hyper, and hypo. Iso, we use it for inward type of sequent, exo for outward sequent. Let's say isotropia, isophoria. This means there is an inward deviation which is manifest, isotropia, inward manifest deviation. Isophoria, inward latent deviation. And the same apply for exo, hyper, and hypo. So we have the direction, and we have a terminology for tropia and phoria. Okay? After we classified sequent into manifest and latent, then we classify it according to the direction, iso, exo, hyper, hypo. Now we come to the details of the manifest sequent. We said earlier, manifest sequent, when both eyes are open, one of them is deviated. This is manifest sequent. It's either comitant or incomitant. This is not another classification, let's say. This is part of the general picture of sequent. Comitant or concomitant, the angle of deviation, the angle of sequent, is the same in all directions of gaze. Whenever the patient looks, it's the same angle of deviation, the same degree of sequent. While incomitant, this is paralytic type of sequent. This means that the angle of sequent vary in different directions of gaze become more or higher in certain direction and lesser in other directions. This is the concomitant, which is paralytic. It occurs when there is cranial nerve palsy usually. Well, the concomitant is the common type of sequent in pediatric age group. Concomitant sequent can include one eye or can alternate between both eyes, while paralytic only involve the eye with the paralyzed muscle. Left, right, both of them, we don't know, according to the patient and what he has. He might have multiple cranial nerve palsy, he might have only one cranial nerve palsy, and so on. So concomitant or paralytic depend on the pathology, while concomitant, it can generally affect one eye, that this eye is the weak one, it will deviate all the time, and the fellow eye always fixating and straight. While alternating, the sequent can occur on the right eye, then it will happen with the left eye, then it will turn with the right eye, and so on. It's an alternating. So uniocular, alternating, it's coming to the concomitant sequent, while in concomitant sequent it depends on the underlying pathology and which nerve is affected. These are both terminologies. We use them with manifest sequent. We cannot use them with latent sequent because latent sequent is practically, there is no sequent. The patient only when covers one eye, the sequent manifests. So it's type of latent weakness, latent sequent. While manifest sequent, there is sequent that we all can see. Okay? Now we will classify the isotropia in general, which is the concomitant isotropia. Isotropia, it can be either accommodative or non-accommodative. This means either accommodation is involved or it's not involved. In the accommodative variety, it's further divided into refractive and non-refractive. The refractive type, it's either fully refractive or partially refractive, and the non-refractive is one type. So, starting with accommodative isotropia, it's related to accommodation. There is a problem with accommodation. It usually starts from age 6 months and above till 5 years. Commonly, the child presents with isotropia by age of 2 years. As we said, accommodative isotropia, it's either refractive or non-refractive. I mean, with refractive, there is some sort of refractive error. Non-refractive, there is no cause of refractive error. A, refractive accommodative isotropia, which is the first type. This patient presents with excessive hypermetropia and esotropia. Let's say the degree of hypermetropia from +4 diopter to +7. This type, we refer to it the fully accommodative esotropia. It usually corrects with the glasses only. We correct the refractive error the child has with the glasses, and the esotropia will correct. Simply, there is no need for surgery. The child will keep wearing the glasses. You can see now with a normal ACA ratio, I mentioned this phrase. What we mean by ACA ratio, it's an accommodative convergence accommodation ratio. This type of esotropia, there is normal accommodation and normal convergence. Normal ACA ratio, there is no problem with accommodation and convergence. So the esotropia is merely connected to excessive hypermetropia. What about partially accommodative esotropia? There is hypermetropia, but when we correct the hypermetropia with the glasses, the esotropia only corrected partially. There is some remaining esotropia with the glasses. In this type, the child might have amblyopia we need surgery in addition to glasses to correct the isotropia. Surgery will correct the remaining isotropia when the child wears the glasses. So we need glasses, and the remaining isotropia with the glasses is corrected with surgery. Now we come to the non-refractive accommodative isotropia. There is no refractive error, no high hypermetropia. The normal range of hypermetropia for a child of age 1 to 2 to 3 years is 1.5 to 3 diopter, so no excessive hypermetropia, but the accommodative convergence accommodation ratio is high. There is abnormality in convergence and accommodation. That's why we call it non-refractive accommodative isotropia. This means there is an accommodative element related to this abnormality in ACA ratio, while the rest, the above two types, there is normal ACA ratio, and the excess convergence is related to hypermetropia. Here in this type, the non-refractive type, there is no refractive error, but abnormality in the ACA ratio. That's why the child will have isotropia. Also, something differentiates this type from the above two types. The child will have no isotropia for distance. Only when the child focuses for near, we see the eye is deviated. Only for near. That's why this type corrected by special type of glasses, we call it bifocals. Bifocal is a glasses, normal glasses, but each eye, the glasses is designed to give two lenses, above lens and the bottom lens. I will describe it with pictures so that you can imagine what I mean. Bifocals is used for the non-refractive accommodative isotropia, which is caused by high ACA ratio with normal refractive error. Bifocal glasses, the top lenses contain no power, 0 diopter, and the bottom lens contain +3 diopter. This +3 will normalize the ACA ratio so that the deviation for near disappears. This picture for fully accommodative isotropia. We see there is isotropia and it's fully corrected with the glasses. This picture is for partially accommodative isotropia. The child is wearing glasses, still there is some degree of isotropia. This remaining degree is corrected with surgery and the child keeps wearing glasses later on. This is bifocal glasses. There are two parts, distant part and near part. Distant part from the name used for far vision and near part for near vision. Usually the near part is powerful, more powerful than the distant part in order to decrease the accommodation of the eye and to decrease the ACA ratio, accommodative convergence accommodation ratio. We use it for non-refractive accommodative isotropia treatment, which is isotropia for near. The second type of isotropia is the non-accommodative type. This means there is no accommodation problem, no refractive error. There is some other causes. We can divide it into many causes. Among these, I mentioned essential infantile isotropia, convergence excess isotropia, convergence spasm isotropia, divergence insufficiency, and consecutive isotropia. These all have no accommodative element, no excess refractive error. Essential infantile isotropia is the congenital type of isotropia to present in the first few months of life. I mean with that exactly before 6 months of age. Usually the child comes from birth or the first or second month with significant isotropia, which is alternating and excessive amount of deviation. Essential infantile isotropia or congenital isotropia, it has certain criteria, usually large angle of deviation, alternating in a primary position as I described. One eye can be fixating at each time. Cross fixation can occur in side gaze. When the child looks to the side, there is a cross fixation. When the child looks in a primary position, the fixation is alternating between both eyes. Sometimes there is nystagmus. Usually there is no refractive error and no neurological defect. All muscles are functioning. Management, the same way as accommodative isotropia, we should do refraction first to make sure there is no refractive error. If there is any refractive error, sometimes it can happen, we should correct it with a glass. We need, in addition to the refractive error examination, we need to examine the retina. It's very essential in all cases of sequent in children to do fundoscopy, which is examination of the retina, to exclude any serious retinal condition. Sometimes it could be tumor, sometimes retinal malignancy, and pediatric can cause sequent. So we need to exclude refractive error and any retinal pathology. Then we go for surgery. Surgery is a treatment of choice for this type of sequent. This image is for a child with essential infantile isotropia. The child here is in a primary position. Both eyes have some degree of isotropia, but mainly in the left eye. As we see, the light reflex is on the margin of the pupil, while it should be in the center of the pupil. There is no refractive error, no neurological disease. In this child, I will do refraction first to detect any refractive error and make sure the child doesn't need glasses. Secondly, we will do fundoscopy to exclude any retinal pathology. Then before age of 2 years, we can do surgery to correct this deviation. Management of accommodative isotropia. Accommodative isotropia, as we mentioned, it means there is some sort of accommodative disruption. It's either due to refractive error or due to high ACA ratio in the absence of high refractive error. So we can divide it into fully accommodative, partially accommodative, or non-refractive. Why we manage accommodative isotropia? We manage it for two reasons. The important reason is the first one here, to restore binocular single vision. Secondly, cosmetic. For the parents, the cosmetic reason is the important, but for us as doctors, it's the first reason, to restore binocular single vision. The parent doesn't know the meaning of this, but we know. They focus on the cosmetic appearance of their child and their acceptance in society, because sequent is not accepted, and we focus on the single vision. What I mean with single vision, both eyes, usually in normal straight eyes, generate each eye an image. The brain will fuse these images into a single three-dimensional image. Three-dimension, you know what's the meaning of three-dimension? It's detailed image from 3 dimensions, like in the cinema. our brain is able to create this type of image. All our vision is a three-dimensional. This is binocular single vision. We all have it. If a child with sequent did not receive the proper treatment, either glasses or surgery, in the proper age, which is in the first few years of life, he will not be able to generate binocular single vision. He will not be able to see three-dimensionally, and his vision will be useless. So as a doctor, our rule is to save his binocular single vision. For the parent is the cosmetic what's important. How we do this? How we can save binocular single vision? Any proper management should start with a proper history. Our history in case of sequent should include the following aspects. We need to ask about diplopia. Diplopia is a feature of sequent in old children and in adult only. Why? Diplopia is closely related to binocular single vision development. Let's give it very simply. Any child or adult with binocular single vision, if they develop sequent for whatever reason, there will be diplopia. But if the child has no binocular single vision, they will develop no diplopia with sequent. How? Let's say a child of 2 months old had sequent and was not treated properly until the age of 2 years, and that's common in our society. Will this child develop binocular single vision? The answer is no. The brain need to receive 2 images from both eyes in order to fuse them and to create single 3-dimensional image. If one eye is deviated, the brain will ignore it, will not receive any image from the deviated eye. So the sequented eye will be suppressed and ignored by the brain. This child will develop no binocular single vision. The duration is critical for development of this single vision. It's only first 3 months or first 4 months of life. After that, the child will not develop binocular single vision. So the deviated eye will send no image to the brain. So no diplopia will happen. What about older child? Let's say 3 years old child developed sequent. This 3 years old child already have binocular single vision because his eye was previously straight. So when sequent will happen by age 3, the brain already recognize both eyes and respect them. If one eye suddenly deviated, this will create diplopia. What about the age of onset? Congenital strabismus is not like accommodative one. Accommodative one usually starts after the age of 6 months, while congenital starts before 6 months. Congenital affect the treatment. In congenital type, we go for surgery. In accommodative type, we might choose surgery, but mainly correction of refractive error is the aspect of treatment. So age of onset is important. General health of the child. Does the child has any neurological illness, including cerebral palsy? These children usually present with sequent. Family history of sequent important. And the way of delivery of the baby. As we said, assisted forceps delivery can cause 6th nerve palsy, and the child will present with strabismus, which is of the incomitant type. After completing the proper history we mentioned, the second step will be these elements. Visual acuity is very essential. Every patient, every child with sequent, we need to examine his visual acuity to know which eye is weak, which eye of good vision. The second part of examination, motor examination. What we mean in that? We test for ocular motility to see if there is any limitation in certain direction. This might imply cranial nerve palsy. The third step is refraction. All children with sequent need to be subjected for refraction. I mean with refraction is detection of refractive error. We do this with retinoscope. In children, we use retinoscope and not autorefraction machine. Because autorefraction machine need cooperation, the child is not cooperative. So we use the retinoscope, which is an instrument similar to ophthalmoscope. After complete cycloplegic effect, what we mean with that, we use usually atropine or homatropine or cyclopentolate. These agents are used during detection of refractive error in sequent patients or in children below 7 years old. All children below 7 years old, if I need to examine them for refractive error, we need to use any of these drops. Then we subject the child for retinoscopic examination. The final step is fundoscopy. Fundoscopy is essential, as we said, to detect any retinal tumor, atrophy, anomaly, because if we missed the main pathology, the treatment is not useful anymore. So any management should start with the proper history, visual acuity, ocular motility exam, refraction, and fundoscopy. Any question, these should be mentioned. The final step of management is correction of refractive error and correction of amblyopia, if there is any amblyopia. We correct refractive error by simply prescribing glasses proper to the condition of the patient. Correction of amblyopia. What we mean by amblyopia? Amblyopia is lazy eye, where the eye, even when provided with a proper refractive correction, proper spectacles, vision will not improve unless we do one of these, occlusion or penalization. We use these two procedures, one of them or both, in order to enhance the vision in this eye after we correct refractive error. So the principle of occluding one eye and leaving one eye is to enforce the amblyopic eye to send signals to the brain so that the brain will acknowledge this eye and respect it again. We choose one eye, the weak eye, and leave it open, and we close the fellow eye. The duration of closure usually is 1 week for each 1 year of the age of the child. Close follow-up is needed in amblyopia. This is important. We should not give occlusion therapy and leave the child for many months. No, like the child is of 3 years of age, we give him the treatment for 3 weeks and then follow up to see any improvement happened or no. Penalization, it means partial occlusion, not complete occlusion as the first option. Partial occlusion by using certain cycloplegic drugs, which is atropine. Atropine duration of action usually 2 weeks. We instill atropine in one eye and we leave the other eye that we want to enforce or enhance. Atropine will cause blurring of vision, so it's similar to the effect of occlusion but partially. So there is still image, but it's some sort of blurring. If amblyopia is mild, we can use penalization, but if amblyopia is severe, occlusion is the best option. We stop amblyopia therapy gradually when the visual acuity becomes equal to the other eye. For isotropia, which is divergent sequent, as classifications, either constant or intermittent. The constant variety, usually when both eyes are open all the time, one of them is deviated outward. It's either congenital, since birth, sensory, or consecutive. What we mean by sensory and what we mean by consecutive. Sensory constant isotropia is due to vision deprivation in one eye, like cataract, corneal opacity. So this eye will be neglected and will drift outward to present as a constant exotropia. This is seen in adult. While consecutive, it's due to surgical overcorrection of isotropia. Patient with isotropia in need for surgery. We did surgery, we corrected, but we give more correction. Sometimes this mistake can happen. This is an overcorrection of isotropia. So the patient was isotropia, now exotropia. We call it consecutive exotropia. Consecutive always post-surgical overcorrection. Let's discuss the congenital variety. Congenital variety usually constant type, as we said. It's large angle, no refractive error, but with neurological deficit. The child has some sort of neurological abnormality. Usually present after birth immediately, and it's constant type. Now discussing the intermittent type. Intermittent usually present at some time of the day, especially when the child is tired during illness, fever, and in malnourished children. This type of exotropia, which is the intermittent, usually reported by the parents, so we should trust the family history. Sometimes we can detect it during examination. For intermittent variety, it's either there is 3 subtypes of intermittent exotropia. These subtypes depend on whether the angle is higher for near or for far. We mentioned simply these notes: exotropia for far more than near, or exotropia equal for far and near, or exotropia for near more than far. This depends on a special examination technique. All you have to know: the nature of intermittent exotropia and the treatment. The treatment for exotropia, usually glasses to correct any refractive error. We should correct any amblyopia, and then surgery if the glasses and amblyopia treatment is not beneficial. So we don't go for surgery as a first step. We mentioned in the lecture few notes about surgery: the recession and the resection surgery. We mean with recession weakening. So recession is a weakening procedure and resection is strengthening procedure. In exotropia, we always go for weakening of the lateral rectus muscle so that the eye will converge slightly. While in esotropia, we always weaken the medial rectus muscle. So in esotropia, we do medial rectus recession, and in exotropia, we do lateral rectus recession. That's the difference between recession and resection. Recession is weakening procedure and resection is strengthening procedure. Now we have few notes about the paralytic sequent, the concomitant sequent. As we said, it's due to paralysis of one of the cranial nerve, 3rd, 4th, or 6th cranial nerve, or combination of them. One of them or combination, one eye or both eyes, or it could be congenital. There is paralytic congenital sequent. Usually surgery should not attempt till there is no hope for a spontaneous recovery. So in any paralytic sequent, we don't go for surgery until 6 months or 1 year has passed with no recovery or improvement. Pseudo sequent is another important subject. A child with his parent come to you in your clinic during consultation time, and they complain that their child face looks like there is some sequent element. You examine him and you see this picture. This picture is a pseudo sequent or pseudo strabismus and not strabismus. Why? You see there is central pupillary reflexes, but the eye looks like it's convergent. Why? There is wide interpupillary distance. The distance between both pupils are very wide, and there is epicanthic fold. Epicanthic fold is an extra skin fold that cover the inner canthus, the inner angle of the eye, so that the whitish sclera at the inside of the eye is not visible. This gives an impression of esotropia or exotropia accordingly. So this is a pseudostrabismus and not strabismus. This condition need nothing, but you should anyhow check for any refractive error in this child, and follow up is important. This is another image of pseudostrabismus. You see there is a prominent epicanthic fold, there is a flat nasal bridge. This gives also an impression of pseudostrabismus, but there is really no strabismus here. The pupils are central and there is no any deviation. This image is another example of pseudo-exotropia. You see this child is with something like exotropia, but honestly there is very wide interpupillary distance and epicanthic fold. This gives an impression of sequent. There is no sequent. The eyes are central. This is very wide interpupillary distance in Asian population usually. Thank you.